Okay, good afternoon, everyone. So I'd like to thank everyone for joining us today and a very warm welcome to all of you. And today is very important panel discussion titled Scaling Access to Palliative Care in India. We are truly honored to have such a distinguished gathering of experts, advocates, and policymakers with us today. It's my privilege to welcome our guest of honor, Dr. Soumya Swaminathan, Chairperson of the MS Swaminathan Research Foundation, and one of the most respected voices in public health to join us today. Dr. Swaminathan has made outstanding contributions to health research and policy, both in India and globally, including her impactful tenure as Chief Scientist at the World Health Organization. We are deeply grateful to have her here with us today. Request you, ma'am, to please share your thoughts and help us frame this important conversation.
Thank you very much. Good afternoon. And first of all, it's good that we have a session on palliative care. It's something that's often not really at the center of discussions when we talk about health. I think everyone in this audience is probably already very committed because then we usually end up talking to people who are all interested in the same topic. That sometimes becomes an issue because what we really want to do is to reach people who are not at all aware and knowledgeable about palliative care. So we know that of people who need palliative care, barely 1 or 2% of them actually have access to it, and especially in a region like ours, the Asia Pacific region, the Southeast Asia region, and even in our own country, India, which is so huge and heterogeneous, we know that an estimated 7 to 10 million people need palliative care, but just 1 or 2% are getting it. And in fact, that need is only going to get bigger because as people age, there are many conditions also which increase the non-communicable diseases, including cancer, but including stroke, other debilitating neurological conditions, and even tuberculosis, which I have spent most of my life. People don't think about associating palliative care with TB, but a lot of people are, do have permanent disability after TB. Their lung health is affected. They are not able to get back to work or the kind of physical work that they used to do earlier. There's, of course, in addition to that, the societal stigma and discrimination for some of these conditions like TB or HIV and so on. So, if you really start looking at the need, then probably the need is much, much more than even what is estimated now. So, of course, there are many reasons why this access is limited. Limited awareness about palliative care. I think it's still a concept that probably a lot of the public don't understand. So there is need for more communication and public engagement and discussion around what is palliative care. It's not. It's also something to do with end of life care that we don't teach well, I think, in our medical and nursing schools. At least I did not have at that time, and even now, I think there are very few medical universities or health science universities that probably include a good curriculum. I mean, one institution that one I have to mention is Pallium India, and everybody knows Dr. Rajagopal and the role that he's played. In fact, he was the one who came to me when I was head of ICMR and talked about the Supreme Court's ruling and the definition of end of life and so on. So that is also interlinked. So I think medical and health education curriculum is where we need to start, because if the health professionals are not aware, then it's a far cry from making the public aware. So I've been working with universities of every state now has obviously a health science university to see how we can include the curriculum both in the training, education of medical and nursing schools, but also for the practicing professionals who are in the field already, who are employed by the government. how do we increase their knowledge. There's also another complicating issue is the restriction on the use of opioids here, and to the point where we're so afraid of
So
overuse,
this is the communication
and there
style.
are restrictions and rules around that people who really need it for pain relief, often don't have access. So I think we have to work at different levels to change the scenario. One is, of course, at the policy level, and so there needs to be a very good analysis of and I'm not an expert, so I'm not going to give you an analysis of the current policy and what the gaps are and so on. But any policy that's made always needs to be re-looked at in the light of how it is implemented and what impact it's having. And I don't think any health policy should be static for very long. I think it
So
must
I
evolve, it must update itself.
send some
There are some programs where it's much more built in terms of gathering the evidence, updating the guidelines, so for drugs and for vaccines, we have institutional mechanisms to do that. But I'm not sure we have it, for palliative care. So that's perhaps something that we need to look at, strengthening the national program for palliative care. And what we really need ultimately is to integrate it into primary health care. So I'm a very strong proponent of primary health care really being our pathway to universal health coverage. And I truly believe, and I've been traveling across India, going to primary healthcare centers and now the health and wellness centers and meeting the CHOs, mid-level health providers. So we are creating that layer in India of people being really close to the community, because one MLHP is in charge of 5,000 population approximately. That is a manageable number for a person to really get to know that population. And so we can actually now provide comprehensive primary health care, which is family-oriented or person-centered, rather than a disease-oriented vertical program, which is the way our system is set up. So we have a lot of vertical programs with reporting, with supply chains, sometimes the protocols, the guidelines. So it does create a burden, and moreover, I believe that is inefficient, and maybe it was needed at one point. We're trying to eliminate malaria, or HIV at that time was new. One needed to really TB, is still a huge problem. The NCD program is also developed like that. But ultimately, you finally depend on that one or two female health workers to deliver all of this. And then she is overburdened with so many reportings that she has to do. And a better approach, and something that we should move towards, is this type of a person-centered. It's an individual who might have multiple things going on at the same time. I could be pregnant, I could also have hypertension, I could have mental health issues, I could get an acute infectious disease, I could get TB, I could get malaria, but I'll be entered so many times into different registers. So I think that palliative care, now we're talking about prevention and health promotion. We've started talking much more about the health sub-centers playing a role in that. But rehabilitation, providing people assistive devices, and palliation, physiotherapy, these things I think still need to get strengthened and become part of primary health care. Education and training, as I already mentioned, community-based models, expanding home-based care services. And some states like Kerala have done this extremely well. So I've traveled out with the Pallium India team into the rural areas of surrounding around Trivandrum to really see how this happens in the person's household, how the family members are trained, and how the community there, the panchayats, actually step in a big way to provide support. That's the ideal. I feel that's the model. The local community leadership takes responsibility to support this family as they're going through this very difficult time, whether it's children's education, whether it's support with food, housing, and so on. This is what is happening in Kerala. But that's because the panchayats there and the local bodies are very empowered, and they also have much more resources than the panchayats in any other state. But to me, that is ideal because in a country like India, this top down, centrally driven will have limitations. You can set policy, but the ultimate implementation on the ground has to be done by people who understand the local context. A village in Kerala is very different from a village in UP. So strengthening the panchayat, strengthening the local institutions, making them informed about issues which affect them. I mean, they already know the issues. We don't have to tell them about that. But what are the solutions for the problems that they face? So rather than being passive beneficiaries of services, how do they become part of it? So again, that's part of the definition of comprehensive primary healthcare is very much a community engaged model where they're not recipients or beneficiaries, but they're part of the system. They can also demand services which are their right. So Kerala has a very good model. There are other global best practices. Of course, WHO has framework for assessing palliative care development and integrating it into national health policies. And we can also do a lot more collaboration internationally as well, domestically, but also with our neighbors in the Southeast Asia region. So certainly we need the government support, you need academia, you need NGOs. That's absolutely important for raising awareness, for mobilizing resources, but ultimately for scale and to have that impact, it has to become part of government programs. And then looking at regulations, looking where does the policy needs change? Are there regulations or laws that need a change which are coming in the way? I think those are the kind of contributions that NGOs and civil society organizations can do because they're much closer to the people, closer to the ground, closer to the reality of what is happening. So, and we need to work together. So sometimes we have this community of NGOs where people are working on the same or similar things, but they're not necessarily coming together. And I think if you do that kind of strength in partnership and strength in uniting and speaking with one voice is much stronger than sort of one or two random voices, speaking up. If you have a very big leader, powerful leader, of course, that might make a difference. But otherwise, I truly believe that NGOs need to do much more work together, form networks, consortium, and I think we can multiply our impact so many times if we do that. Thank you very much for giving me this opportunity.
Thank you very much, Dr. Soumya, for your inspiring words and putting things into context. Would request CanSupport Dream Managing Secretary Radhika Shapuji to present a small token of appreciation from our side to you, Dr. Soumya.
Thank you so much. Sorry. Thank you.
So before we dive into our panel discussion, we are honored to present a very special video message from Dr. Catherine Pettis, who is the Senior Advocacy and Partnerships Director at the International Association of Hospice and Palliative Care in the US. She unfortunately could not join us today in person, but she is kind enough to have sent a video message. So in this message, she talks about what palliative care means, the basics of palliative care, and why it must be seen as an essential part of healthcare, not just in times of crisis, but as a fundamental right for all those facing serious life-threatening sicknesses. So can we have the video, please?
My name's Dr. Catherine Pettis, and I'm going to tell you how palliative care is changing the world, one bedside, one patient, and one caregiver at a time. The word palliative, as you probably know, comes from the Latin palliare, which means it also is part of the word pallium, that root, which means to cover. And the definition that was evolved through a year-long strategic planning process and research was the active holistic care of individuals across all ages, with serious health-related suffering. I'm going to define that in a minute, due to severe illness, and especially those near the end of life. So it's not just for people at the end of life. It aims to improve the quality of life of patients, their families, and their caregivers. And this is where you can find the definition on our website, iahpc.org, and then what we do, consensus definition of palliative care. And a friend of mine who runs the Atlantis WHO Collaborating Center in Spain has called it the medicine of the future, but it's also the medicine of the present. So I said I would define serious health-related suffering, and you will also find this on our website and on Pallipedia. It is associated with illness or injury of any kind. So that's when there's the suffering. It's health-related. It cannot be relieved without medical intervention. It compromises physical, social, spiritual, and or emotional functioning. So it really is a form of total pain. It carries a high risk of mortality, and it negatively impacts the quality of life and daily function. It's burdensome in terms of caregiver stress, treatment, and symptoms. So this concept of serious health-related suffering was introduced in the report of the Lancet Commission on Pain Relief and Palliative Care, and it really is an important part of our advocacy, our research, and everything else. There are many other components of the definition that you can read on the website. Serious health-related suffering in the world now is estimated at about 74 million. I think that's per year. I tend to think that's an underestimate, but that number is increasing exponentially as populations age and the burden of communicable and non-communicable diseases grows. And the WHO estimates that only 14% of people in the world who have palliative care needs, so serious health-related suffering, actually receive palliative care. So the burden of SHS is expected to double by the year 2060, with the fastest increases in low-income countries. Around 7.2 million Indians are noted to have serious health-related suffering every year. That is from a 2016 study by Catherine Sleeman. It's probably by now, that's almost 10 years ago, more than that. So that's an enormous burden of serious health-related suffering that, as I said, also affects caregivers that can be relieved with palliative care. Benefits of publicly provided palliative care are very important. We advocate for publicly provided palliative care for those whose diseases are no longer curable, because private and charitable funded services, no matter how wonderful they are, and they're all over India, cannot treat the millions who need it. So your government, as a UN member state, has committed to this under the Palliative Care Resolution approved in 2014 at the World Health Assembly and in the Declaration on Primary Health Care, which was approved in Astana, Kazakhstan in 2018. So according to those resolutions and declarations, palliative care must be included in all levels of care of a health system, including outpatient home settings and tertiary hospitals. So good health and well-being for all, which is one of the Sustainable Development Goals, will not be available to everyone unless palliative care is available to everyone. It improves patient and caregiver quality of life by relieving health-related suffering. It promotes workforce integration and increasing savings at the whole household and health system level. Palliative care education enhances bedside skills of all clinicians, not just palliative care docs. It also, interestingly, increases trust in government, and there are several studies that show that. And it prevents catastrophic out-of-pocket spending on futile treatments, which are offered when palliative care is not available. So that works both at, as I said, the household and the ministry level. That's what you can use for advocacy. Palliative care is changing the world for the better. As I said, it strengthens health systems, it inculcates compassion, and it cares for caregivers. So I urge all of you who are attending the World Health Summit to advocate for palliative care services to relieve serious health-related suffering. All the governments of the world who will be attending that health summit, including India, have officially committed to it in these global organizations. And it's now up to civil society organizations such as yours and our friends in government to make this happen on the ground so that families can get the support they need during very challenging times. It does not have to be that way with lots of serious health-related suffering towards the end of life, and I know that very well, having cared for both my sisters, accompanying them to their next destination with good palliative care. Good palliative care support, there's nothing that beats it, and without it, it's not a pleasant journey. So I want to finish with a quote from one of your great poets, Rabindranath Tagore. He said, "Death is not extinguishing the light, it's only putting out the lamp because the dawn has come." And palliative care is with patients and families as the light itself until the dawn comes. So thank you for inviting me again. And I hope that those of you who go to the World Health Summit will take this responsibility and this message to the World Health Summit.
So without any further ado, let's now dive into the panel discussion. We have an esteemed panel of experts who have joined us today for this discussion. So request all of you to please come up and take your seats. And also request CanSupport's Honorary Secretary, Radhika Shapoorji, to moderate the discussion.
Testing. Yeah. Thank you, Anand. Hello, everyone. Welcome to the session on how we're going to scale palliative care in our country. That's the topic for our discussion today. I welcome all of you, and of course, I welcome our esteemed panelists who are going to give us knowledge and who are going to look at a forward planning on how as what you just saw with what Soumya had talked about and what Catherine had talked about, that we have only 1 to 2% of people who have access to palliative care out of the 7.2, 7.4 million people. So it is my honor where we are joined by a very distinguished panel of leaders and change makers who have been at the forefront of advancing palliative care in our country. We have Dr. Alok Mittal, and it's not in the same order. So, Dr. Alok Mittal, you could just, yeah, Mathur, my mistake, who's the Additional Deputy Director General at the Ministry of Health and Family Welfare, who steers India's national program for palliative care and healthcare for the elderly. I was talking to the doctor and said, you know, we are going to talk about what is the policy and how can we institutionalize palliative care in our country. Then I have the pleasure of introducing Dr. Shushma Bhatnagar. She's a senior consultant at the Indraprasth Apollo Hospital and the former head of palliative medicine at AIMS, where she spent most of her professional career and spearheaded national level palliative care protocols and educational programs. And Dr. Shushma has also been a long-standing partner at CanSupport. And I thank you so much for your support over the years. It was so lovely to speak to you and hear your wonderful feedback on our teams and what they're doing for cancer patients. Thank you so much for that. And we have Dr. Gayatri Palath, who's a professor and head of pain and palliative medicine at the M&J Institute of Oncology, Hyderabad. And she's one of the key architects of the Telangana's district-level palliative care model and a passionate advocate for pediatric palliative care. She has traveled all the way from Hyderabad to participate in today's discussion. Thank you so much. We were having, again, a discussion on forward planning, and the kind of work that Dr. Gayatri has done was so impressive. So thank you for that. And we have Dr. Prakash Fernandez, who's the head of palliative care partnerships at CIPLA Foundation, which is widely recognized for its impactful work, training ASHA workers and fostering sustainable partnerships. I must mention that we have a wonderful, CanSupport has a wonderful new partnership with CIPLA, which has just been finalized in April. And we have included a whole lot of new teams in Maharashtra, and we're working with the CIPLA Foundation, and I'm sure you will talk about how we, the private sector and NGOs can work together in such a deep manner to have impact. And of course, there's Dr. Bhavna Sirohi, my partner and part of the MC in Managing Committee in CanSupport. Dr. Bhavna Sirohi is a medical director at BALCO Medical Center and known for her leadership in integrating oncology with holistic patient care. Dr. Bhavna has served as, of course, as I just mentioned, is the managing committee member at CanSupport for many years, and she brings, 15 years, and she brings an amazing depth of knowledge and compassion, where she's not just worked in India but in the UK, and she has a deep understanding. And so we're going to really have a wonderful panel out here who can share a lot to all of you. So I'm going to start. Uh, with Before I actually go in, I'd like to say a little bit about CanSupport. I you know we've been CanSupport has been was born 30 years ago almost, and it was an organization that has been founded in 1996 by a cancer survivor, Harmala Gupta. Amazing lady, should have been here actually, but she had to go for some urgent meeting. Which and therefore is not here. But she really pioneered home-based palliative care, and we are the largest home-based palliative care in this country, and I believe across the world, in terms of the numbers, where we have 47 teams across North India, taking care of 30,000 families every year. And what is beautiful, that is very person centric, and I think we heard that we have a nurse, a doctor, and a counselor who goes to these patients who really crave for that weekly visit. I've been there, and they need the care, the compassion, and the holistic way in which their emotional, medical needs are taken care of. And that model that has been created by CanSupport is a unique model. In fact, they've done some amazing research that is set up best practices that are being that we also have government partnerships. In fact, just today we are signing an MOU with the Punjab government, where our people are going to train and advocate palliative care at the district level. So there's a lot of work that's required in this area, and CanSupport has actually created models which we will also talk about. We've also talked about the Kerala's community-based based approach, which I think will elaborate more on other such state partnerships with on this panel discussion. And this discussion is really a step forward, where I'm sure you will listen, you will share, and learn about how to make palliative care integral to the healthcare system in our country. So, on that note, I'm going to start with the first question, and I have a series of questions. And so that it has some a kind of framework, and we use this time well, we are going to talk about policy, we are going to talk about partnerships, and we're going to talk about training and advocacy. These are the four areas that are the challenges that we face, but we're going to talk about best practices and learning around these three. I'm going to start with policy and institutionalizing of palliative care in our country. And I'm going to start with Dr. Alok Mathur. Dr. Mathur is a key enabler for public health delivery, and he has worked on the policy. He's worked on the National Health Mission. I would like to ask you to share with us what is it that what is the kind of policy, and how is it being integrated at the district level? So, Doctor, I'd like to start this with you, Dr. Alok.
Yeah. Thank you so much, Radhika, and good afternoon, all of you. First of all, I would like to make a small correction here.
Yes.
We have yet to finalize the policy. In fact, we are working on the draft policy document, but we have a program in place that is called the National Program for Palliative Care. So, the activities which we are carrying out under this program, we are trying to integrate with the general public health system at all the levels. At all the levels means right now we are focusing on the district hospital level. In this direction, at the district hospital level, we have the palliative care unit in place. Out of the 655 districts which have been approved under PIP. PIP is a is a process, I would say, through which the central government releases the funds to the state governments on some kind of a ratio sharing basis. Okay, 60-40, 90-10, 90-10%. There are two kinds of ratios. So in the PIP, the states put up their proposals that these are the districts for which they seek funds for carrying out the activities under different programs. One such program is the National Program for Palliative Care. So in this, as far as palliative care program is concerned, as of now, out of the 655 districts which we have approved throughout the country, 550 districts, in 550 districts, the palliative care units are functioning. I was talking to Dr. Bhatnagar because she has been our you know, in fact, the leader, technical leader throughout in implementation of this program, right from preparing the training modules, carrying out the trainings and all. So she was telling me that in almost all the districts of Bihar, I'm specifically telling you about Bihar because I went with her to meet the principal secretary of Bihar. At that time, there was not a single district for which that state had proposed to take funds for carrying out the activities in the palliative care program. So, Dr. Bhatnagar, along with the team of the central government, we all went there. We met the principal secretary, and today, that was long back. I think 7-8 years back, we went there in Patna and we met there. So right now, the good news is that almost all the districts in Bihar they have a palliative care unit in place, and at that level, at the district hospital level, we have the physiotherapy unit in place. That that is not under our program. That is under the National Program for Healthcare of Elderly. So we just want to integrate the things. We cannot have a separate physiotherapy unit under our program when a similar kind of facility exists under different program at the same level. But we want to integrate. So we are integrated with various other vertical public health programs also, like physiotherapy unit. We have a mental health clinic in place, mental health team in place at the district level under mental health program. We have daycare centers, cancer care centers, which some of which are coming up now and some are already in place. So similarly, there is one more platform, that is eSanjeevani, also in place. So through all these activities under different programs, we are integrating our program also, so that the needy who need palliative care, they need the care, the quality care, at least at the district hospital level. And besides the district hospital level, we are working in integration of palliative care services at Ayushman Arogya Mandir block level, and of course at the district hospital.
Right.
And you had talked about the policy also.
Right.
We are preparing the policy, and it's on day before yesterday only we had a meeting, a big meeting under the chairpersonship of our Director General Health Services, and in which we have proposed to expand our program to the tertiary level also. We don't have tertiary component right now. So we would be involving the apex hospitals also.
Right.
The tertiary hospital, we would be funding them also.
Wonderful to hear the kind of work that is being done by the government and how it is being taken on such a serious note. And in fact, from there, I'd like to come to Dr. Gayatri, who has done a whole lot of work in Telangana. And can you elaborate and share with our public out here on the work that you've done, and what are the practices that have worked to bring palliative care to the forefront, as we were talking about a little earlier?
Thank you, Radhika. So, speaking about Telangana, so first of all, let's understand who needs palliative care. When we are planning a program, What's the kind of population we are thinking about? Can you hear me? Yeah. So India has seen a very interesting transformation in terms of epidemiology. Like we all are aware, like we are still struggling with infectious diseases, but like as Dr. Swaminathan mentioned, there's a steep increase in NCD. So if you look at the state I come from, Telangana, 70% of how people are dying. So we are all, it's all about people living with life limiting conditions and so serious health related suffering. So in Telangana, which is a prototype of again India, 70% of people in rural Telangana are dying of NCD. That means out of 10, if you have 10 people today, out of 10 of us, 7 are going to live with some kind of life limiting non communicable disease today for a considerable period of time with some or a lot of suffering towards end of life and then die. So that's a huge number. Yeah. So it's that context when you're planning a program, so it has to be really robust, and that's the reason the experts from the IHPC, WHO, and from Government of India, we are thinking how to make it robust from tertiary to the primary level. When we started this program in Telangana, 2017, briefly, I'll just a couple of minutes to tell you. So I work in a tertiary cancer hospital. On an average, I see around 70 to 80 patients for cancer requiring palliative care every day, and almost 50% of them, I would say, which whom I see every day, they are from the districts. They are not from Hyderabad. So I live in Hyderabad. So over a period of time, these patients with cancer, as the disease progresses, they can't come to Hyderabad. They just stay back in their homes. They suffer in their home and they die. So this is just about cancer. So soon we realized that this is not helpful. If we really want to reach out to them, we need to have something right there closest to their home. And that's how we started this Telangana program of district-based palliative care program. We started in 2017. So today we have every district in Telangana, 33 districts, one palliative care center in the district hospital with a dedicated staff of doctor, 5 nurses, a physiotherapist, taking care of just these patients with cancer and non-cancer conditions. And these programs are supported by community home care program. And while parallelly we were doing that, parallelly we did massive training of all the community health workers. We didn't burden them like how Dr. Swaminathan was mentioning. They're overburdened. We just told them while we doing this training that if you see, what is palliative care? If you see patients with these disease conditions, refer to us. And this really helped us to form a very linkage of referral system. So better referral pattern from the home household to the center where we were running it. So this was a program which we developed, and today it's running in all the districts. Now, why I mentioned this program is that because this discussion is about policy. How could we achieve that? Dr. Alok Mathur says policy is still not in place, but we have this national program for palliative care, and this program in Telangana happened because of this program. Because at that point of time, the government was very aware. They had this vision, and they said, "How do we push for this?" And we approached the central federal government. We got the funding, and we could use that funding to roll it out. And today it's going on. So in an automated mode is going on. So that's why policy or some kind of program and fund availability is so important to make it happen. Yeah.
Thank you so much for that, Dr. Gayatri. I'd now like to have Dr. Shushma, who's a key voice in the Indian Association of Palliative Care, in terms of how do you see India aligning with global policy recommendations on palliative care, and how does this integrate into our national health system? If you can elaborate on that, Dr. Sushma.
So, globally, if I say that we are aligned with the integration of palliative care, I will say that we have done a lot, but we have to do a lot. Means we have. I want to say that we have done almost 20-30%, but we have to do at least 70%. So aligning of palliative care, if I can, because right now I'm working in a corporate sector where I see doctors and they say that we have a palliative care program where we start right from the emergency, right from the in the ward, in the hospital, everywhere. It is an integrated program, and when I see that it is not happening in all the hospitals, so we have done a lot in the sense that I've like in AIMS, if I talk about 3 decades back, there was no palliative care, but now in AIMS, every department has a palliative care. It's like every, it is not only in oncology, but it is neuro palliative care, cardio palliative care. It is very structured program. As Gayatri says that 60 to 70 patient every day. We also used to see 100 of 60, 70, sometimes 60, sometimes 70 patients. And what I used to find that these patients are coming from far away places. So what we have started working, that we have started developing institutions based programs. So we have started and we have created 70 institutions all over the country. Then I realized that creating institution based program will not be sufficient. Then we took a fund from ICMR, and I think it was a good funding from ICMR and AIMS funding, and we have developed a program that is for district hospitals. And in district hospitals like in Rajasthan, in Uttarakhand, in Jammu Kashmir, then we started calling doctors and nurses, and the doctors nurses were mentored by these our institutions which we have created. So it's like the way we have developed at advocacy level, at capacity building level, we have done a lot, but still we have to do a lot. If I still think that a patient who is in the far away places, if he is having pain, he will get morphine, it will not be. Many places it is not possible. So we have to work a lot in terms of, like Dr. Mathur, Dr. Gayatri, we all are working, and but you know it is 1.38 billion population, and we have to if we really want to cover, we, and what I always say in government, in all meetings, wherever I go, wherever I get an opportunity, that we have to integrate in the curriculum. If a MBBS doctor, if a nursing BSc nursing nurse, if she will know that this patient, whenever patient is suffering with a chronic debilitating condition, my attitude and my thought process should change. Then only we will be able to change, because you know we keep on working with institutions and district doctors, but if we will not inculcate with the curriculum, I don't think that we will be able to sustain this program. Because a doctor who is coming out after doing MBBS, if he is doing MD, he should know that this patient who is in the end stage of cardiac disease, he should be treated in a separate, different manner. Only diagnosis and treatment is not my responsibility. There is a responsibility lies when patient is in the end stage of the disease, or patient has reached where cure is not possible. My attitude to change, my communication skills to change, my every possible places where I need to talk to the relatives, I need to talk to the patient. I think this, according to me, Dr. Mathur, I have missed, like I must have met secretary also, and many times I've said that in MC we have to integrate pain and palliative care program, or palliative care concept of palliative care, concept of end of life care, to the budding doctors and the budding nurses, so that they are the one who will go ultimately. Because if we will keep teaching, and you know, it is really, it is going to be a long journey. So I have an experience of institution based palliative care program. It was a huge struggle, but I have a very good experience of Harmala. I think when you said that Harmala started, I was the one who we were working together when they were having one team. And you know, first foundation course of palliative care when we did, there were only 12 participants. And out of 12 participants, 5 were my residents and 3, 4 were outside. So for now, when we do, this time we have done, I don't think, I think 25th, 22nd foundation course. And you know, we have to stop registration, that we can't take more than this because the hall is full. And today also, I am very happy you said that halls are empty, but this hall is full. There is no place to sit. So I think people are realizing its importance, and the way we have worked with CanSupport, I think this partnership is required, because the AIMS and CanSupport partnership has become a landmark for everyone. That the way any patient who is in my OPD now, I from Apollo Hospital, I think that if this patient needs home-based palliative care, we are trying to develop home-based palliative care program for Apollo Hospital also. But till the time we develop, I think I'm sending to the CanSupport team, and they are looking after our patients so well. If they are having any difficulty, they talk to us. We are teaching their doctors. Their doctors are helping us in taking care of the patient. I think this kind of public-private partnership should go. It's not public-private, but it's like I can't say that how much CanSupport has helped us. So this is what, and how many doctors and nurses we have trained through the foundation course. There are many. So there are programs are going on. People are getting trained. Residents are get. We have started MD and DNB. Residents are getting trained. They are doing MD and DNB. But we should have a robust hospital that they will take up, where they will get the job. And these doctors also, we should create a system that when they will go to their places, they will get a job, and even if they are in the district hospital or in the state medical college. So I think a lot of work to do, and
Lot of work.
there is a lot of disparity, but a lot of things we have done already.
Thank you so much, Dr. Shushma, and thank you for your appreciation for the work that has been done. It means a lot to us, and I'm sure Nirmala will also hear this. Um, I think if there's anyone else who would like to contribute to this conversation on policy, where I mean, if the key points that I've taken, which is we still are in the process of having an overall policy that is for the country. I think there are some policies in specific areas that exist, but it has to be integrated. What I hear is the need for compassion and understanding of palliative care by the entire community, including the doctors, and and I think you would like to say a few words on this as well, Dr. Bhavna.
Yes, so I have worked in a universal healthcare model in UK, and then since then have worked in the corporate sector in India, in Tata Hospital, which is a public hospital, and now working in a not-for-profit organization in Chhattisgarh. So I think between policy and programs and planning, there is a gap, and somehow as a country we have to see how we fill that gap. So in my hospital, we see almost 250 to 300 patients per day. And 80% of patients who come from rural Chhattisgarh and tribal Chhattisgarh are stage 4 patients. And I would assume that, at least 150 to 200 of those patients need to see a palliative care doctor. And there are enough studies. I'm an oncologist, huge proponent of palliative care. The first time I came back to India in 2009, I was literally swimming in mud because I had nowhere to send patients. That's how I met Harmala. And that's how I met CanSupport. And I was like, this was a boon to my patients, patients ending up dying in ICU. And for them to die at home with surrounded by their loved ones, their spiritual needs taken care of, their physical needs taken care of, was like a breath of fresh air to me. And I think this is the model somehow we have to somehow drive across India. I can't have those 150 patients in my hospital see a palliative care specialist. So somehow how we bridge that gap is something which central government, state government, and also as key stakeholders, all of us sitting here, we have to somehow find a way to bridge that gap, I feel.
Right. Thank you, Dr. Bhavna, for that. I think there's a lot of work that needs to be done, especially we're talking about end of life, a very, very difficult time. I think we're also talking about sensitization of our community towards this, for this integration. I think the partnership that's required between government, between the NGO sector, between the private sector is something that is very crucial. It is not one part, but an integrated model that needs to address the most difficult crisis time for any family and person who's going through the end of life process. And on the next topic, which we are going to come to, which is partnership, I think we've had some wonderful partnerships, as you can all hear. I'd like, again, Dr. Bhavna, I would really like to hear from you about your deep involvement in oncology and palliative care, and how partnerships between oncologists and palliative care providers, if you can elaborate more on that, because that's what seems to be coming through. What is this partnership and how can it roll out into the future? What does it look like?
So, I think as an oncologist, I feel that there are these myths that palliative care is only for when a patient is dying or it's for pain control. Or there is another perception or myth, especially in India, that we've given up treatment. So families themselves feel that, they don't want to take up palliative care. We don't have conversations with patients where we've reached the end of life treatment options. So I think early referral to palliative care is very, very important so that, patient builds a relationship with the palliative care doctor. And there are enough studies which show that, if patients have early referral to palliative care, they actually have a better quality of life. And as oncologists, it's all about patients living longer with a good quality of life. These are the two aims of care that we should have. And the other thing I feel is my patient. So, it's not my patient. Patient should have the option to see whoever. It's our patient. That's very important. So in revenue driven models, you have limited pot of funds. So you have to get a psychologist to see the patient, a dietitian to see the patient, a palliative care, oncologist, treatment. So I think somehow we have universal health coverage in Ayushman, but a lot of palliative care treatments are not funded. A lot of palliative care procedures are not funded. So, and I struggle with that every day because 70% of my patients are on the Ayushman scheme or another state government schemes. So somehow within the UHC model, and I think the PMJ scheme, Ayushman scheme, is a boon to our patients because some of these patients would have never traveled to bigger institutes like AIMS or Tata Hospital, and now they are getting care closer to home. So which is fantastic. So there's nothing taking away from the scheme, but I feel that somehow there are two things we need to prioritize. One is palliative care, which is not just about dying and pain control, and prevention. So
Right.
these are the two things, which I feel as an oncologist we need to talk to all the stakeholders and prioritize that.
Yes, thank you, Dr. Bhavna. Absolutely, because how can we enhance the quality of life and how do we give hope? I think I hear that from you, Dr. Bhavna, and I'd now like to come to Dr. Prakash. Given your experience leading the National Palliative Care Partnership at CIPLA Foundation, what models of cross-sector collaborations, that is between government, NGOs, academia and the private sector, have proved most effective? If you can talk about that, I think that will give us more knowledge on that front and some best practices.
Yeah, no, thank you, Radhika, for inviting us on this panel. I think really partnership is the way forward to implement policies. I think it's great to have the policy in place. And as we've said, on the ground, how do we get it off? I think it's many stakeholders coming together to make that difference. At CIPLA Foundation, we've been privileged in a sense to start a palliative care center in 97 and then support about 45 projects across India who are delivering palliative care, several on this panel as well. And I think that's the key thing really, to see how we work together and bridge different strengths of partners coming together. I think it really struck me when I was in Goa last week and I met a gentleman at a sub center actually who was in a wheelchair sitting up. And he told me really his story of how he got there. When he was 7 years old, he was taking part in a school play and there was a thunderstorm and the stage fell on him, leaving him paralyzed. He used to be carried to school for a couple of years and then they stopped taking him to school as well. And basically, he lived his life lying down and seeing what life was just stretched out. He was eating his meals, which would just be propped up a little bit. His mother used to sell vegetables in the village. And that's when we kind of come back to when he was about 32 years old, which was a year and a half ago. And he had come to the South Goa District Hospital because he had come to change his catheter. And that's when the palliative care team, which has just started there, got kind of saw him and asked him what was happening. And his mom explained what had happened. And slowly they realized that there was much more potential with physiotherapy. They started talking to him about his fear of why he would not sit up. And he said because he thought the catheter would fall off. And so he just was flat. The physiotherapist started working with him, the occupational therapist as well. They got him to sit up for 5 minutes at a time. And that's when he kind of got more confident. They got him to move to a bed as well. Slowly, they got him to cut vegetables with the mom, make chapatis, gain his confidence back. A few months later, he was making Diwali cards. He then got into a Christmas party and was kind of making envelopes. And recently did an exhibition. And now he was at this sub center being an inspiration to people who are coming for a neurology clinic, which they have every week in South Goa.
That's
So
amazing.
this was a story really which showed in a sense how one individual, but how this could happen, I was just reflecting is, which is the positive sides of it, is what there was a palliative care team and that was supported in the South Goa District Hospital with a partnership, therefore supplementing the National Health Mission staff with other staff as well. So it was a combined team, it's a joint effort, palliative care at the district hospital. They have a community, a compassionate community program that they have, which is therefore going into the communities now to identify who requires it and working with community health workers to follow up. So it's a shared care in the community as well. So I feel it is possible if we all come together to do it, but also it kind of highlights that for about 30 years of his life, this did not happen. So there are many more people perhaps who are missing who need this kind of care. Um, and I think, therefore, the more we can work together, and the foundation's policy really, we really want, for us, what does scaling up actually mean, I think, is when communities can take ownership of that. When you have local panchayats, therefore, who are involved in this work, who can, transport is a big issue of how do you get people in to the centers. So if there are kind of budgets available which they take ownership for palliative care, I think we can really grow this project. But it really requires everybody to come in. So you have the government, which is absolutely necessary to provide the basic HR support, that core team of palliative care professionals who are in every district hospital, where you have morphine, pain relief, essential medicines at the primary healthcare centers that are available and accessible. You need NGOs, therefore, to be able to ensure that training happens, because that may be the strength to enable the staff to see actual projects where it's working, to ensure that SOPs are in place. Because I think if we're talking about quality care, we must ensure, therefore, that there are certain processes in place which are being followed. And I think NGOs can really help in make that kind of come true. I think academia is very important because really we don't have enough evidence based in some ways to really share the models of care that are happening and celebrate them actually of so many positive things happening across the country. We need more kind of research in this area and more writing up of this work. Development of quality standards is something as well at the foundation we've worked on. Dr. Sushma, Dr. Gayatri have been actively at the association as well, working with people, therefore, to develop these standards. And I think like CSR foundations, family foundations need to come in, therefore, to partner, to have holistic plans, I think, not to duplicate work, but really have concentrated efforts of working with government. So I think joint up this can happen. I think in terms of the models we've worked with CanSupport very well and very deeply, I think, in our work, because we've been able to expand in Punjab and Haryana to show that home care is possible working with the government. To set up, for example, at Rohtak PGI, you've been able to base yourselves out of sometimes an OPD. So while if we talk of continuum of care, there are many institutional models, but how do you extend that into home care? And those are the gaps sometimes that people may have. I think NGOs can fill that gap. CanSupport does an excellent job in that. We work, of course, very closely with Dr. Gayatri at PRPCS to look at pediatric palliative care. And I think working at Nilufa Hospital, which is a busy government hospital for children, therefore, is how do you ensure that joint up care happens, and how do you kind of have people there within the OPDs who are working alongside government staff to show how that compassion can really translate and make a difference. We work a lot with the Tata Memorial Hospitals, and there they take ownership themselves, so it's supporting them to do home care services and extending their care. Or at AIMS, for example, in Jodhpur and Rajasthan that you mentioned, Dr. Sushma, has really done a great job in getting the community involved through the ICMR project. And of course, with Pallium India, I think in Srinagar and in Kolkata, where we've worked with them, they've been really be able to extend these models. So I think it's really possible, but I think there's joint up and all partners coming together to make a difference.
Thank you so much, Dr. Prakash. I'm sure all of you could hear the passion and what true partnership means. And you've really been able to bring alive that with that wonderful story and how it affects every person. I think we need to have a personhood where every person gets that care as a community as well. And thank you for sharing on that. On the same area of partnership, I'd like to come to Dr. Gayatri, who has been a pioneer in the NGO government partnership, and you talked about it. I think, could you talk a little bit more specifically on how these partnerships can actually work, and is it possible to take it beyond just Telangana? If you could talk about that as well.
Thank you. I work in a government hospital, but I'm also a founder member of an NGO called Pain Relief and Palliative Care Society. And the Telangana project which we started, it happened. Yes, we had the support from the central government, but one of the main reason we could roll it out in all the districts in Telangana was because of NGO government partnership. And I think that was a very unique and very beautiful model, and it could happen. It's not easy. We were discussing that NGO is always seen with eye of suspicion by the government. They really don't like it most of the time. So we got this window where that particular point of time the government was looking around. They wanted to do palliative care. They did not have any good program in the system other than the cancer hospital program. So I was within the system, so I could direct them to the NGO. This NGO has a very strong presence in the community in terms of hospice for adult and children and home-based program in the city of Hyderabad, extensive coverage. Now, how NGO could help the government? One is when suppose tomorrow we are trying out a similar program in some other districts, other state, the NGO has to be credible. The government should not see them with suspicion. So the credibility is so important, and credibility comes with your work and credible people who are there within the organization. So that is something very important, and we have to showcase what we are doing. So we had a very robust program in the community, and we told the government it's possible. Home care is possible. We can secure morphine even in the most remote place and use it safely, because they are very concerned about drugs, things like how do we procure morphine in a tribal area? Where will we safekeeping and dispensing? So we could show them by actually happening in the community. And there's important. The NGO has to have this commitment, because it's a lot of effort. So tomorrow you're going to roll it out in Punjab. I'm sure it's going to be so much of a intense hard work. The commitment coming from the NGOs in terms of manpower, availability of resources, a lot of the commitment. Unless we have that kind of provision, we can't do it. And then the training part. Dr. Soumya was talking about training. See, when we talk about training in palliative care, we are dealing with patients who are with very complex issues. Imagine people with multiple system involvement. So when they have suffering, it's very intense suffering, and you should have the knowledge normally which we don't learn in our medicine or nursing practice. So that training is so essential. But the training, what you need at tertiary level, what you need at secondary level, what you need at primary healthcare level, it may vary depending upon where you work, but you need that training. And training, it's not just about the medical training or nursing training. It also, what we showcase when we train them is the value, because normally we don't talk about death and dying. Here we are exposing them to how do people die, how to take care of dying, and the compassion value. What we inculcate is, I think that what they take back home is most important in the training than anything else. So providing that that we are able to provide through NGO, and NGO's preparedness that they have to invest so much of time and energy. If that is not there, we cannot do it. So NGO traditionally, historically, if you look at palliative care in India, it's mostly NGO driven. It started NGO driven, then it became little institutionalized thanks to Dr. Sushma's effort. But the way forward is it has to be a combination of both, a partnership, because government has a lot of gaps, and we have to fill up those gaps with the help of NGO.
Thank you for that. Absolutely. Yeah, in fact, that's the last part of what we're going to be discussing, which is training and capacity building. Yes. Yeah. I know we're going to take questions after we finish with the panel discussion. I'll certainly come to you. Coming to the last part, I'm coming just to you, Doctor. In fact, that was, I'd love to hear from you on the role of capacity building and training with NGOs, and how can this partnership go forward? Could you please elaborate on that, Dr. Alok?
Yes, Radhika. Before I talk about the capacity building, I just want to give you this information that in the new draft policy document, developing partnerships is going to be a key element. So we were talking about the partnerships, developing partnerships. Before coming back to the NCT division, I used to work in the Central TB division for elimination of tuberculosis. I have gained a lot of experience from there of developing partnerships, not only with the private sector but with the line ministries of the government of India. So in fact, two of my colleagues, who used to work with me, they are sitting here only. Neelamji and Vijay both are sitting here, and from there I have gained that experience and knowledge. That's why in this document it is going to be a very key and integral part of the palliative care delivery in the country. So this is, I think, a good news for you. Now coming to the capacity building. Capacity building is again, in my opinion, because in Central TB division also I used to look after the capacity building part. There are so many components in the Central TB division. It is very close to my heart, the training, capacity building. Here also we are taking up the capacity building in the form that it's an ongoing event. Conducting the training of trainers,
Right.
and the cascade training. It's going on.
Yeah, just one interruption. I've just got a warning from them that we are coming towards the end of our time. Yes. So no, after Doctor Alok.
Okay.
Yeah,
Okay.
yeah,
I'm just
yeah,
summarizing
yeah,
it.
yeah.
So capacity building is going to be a big thing, because unless and until we train our staff well on palliative care, we are not going to run our centers, operationalize our centers. We are in the process of operationalizing all the centers for which the states have asked the grant. As I had just told you, that around 100 centers are still there in the states which are not operational right now. If when we ask to the states, why are these centers not operational when you have taken the funds for that, they say that we don't have any trained manpower for that. For me, this is going to be the primary focus area of developing the manpower. The quality education or the training should be given to the staff there, so that they can operationalize the centers for which they have taken the grant in also.
Right, right. No, absolutely. I think we are coming to the end of this panel discussion before we can get questions from the group. We've covered policy, covered partnership, we covered training and capacity building, and the importance of it. And I think the very key important message is that we as a society, as a community, have to have more heart, more compassion, and really help and surround to make this happen, because this is what's going to happen as the medicine of the future. It's the medicine of today. I will we'll take some questions from the audience. I can see a hand over there. Can you just tell us your name, your organization, and then the question, specific questions aimed at who would you like the answers from, and I'll help.
Yeah,
on
my
that
name is
also.
Parth. I am from Association for Socially Applicable Research, ASIF. I have requests. I have three requests for each one of you. I'll start with Dr. Prakash. The number that we use for 4% people get palliative care in India is from 2017. And I think CIPLA can drive the research forward of how many people are getting palliative care in India, considering you have a network across country. My second request is from Dr. Alok. We analyzed the essential medicine lists across 27 states and the national essential medicine list. None of the lists have all three formulations of morphine, which is syrup, tablet, injection. 17 state essential drug lists don't even have tablet morphine in them. So can you please push for a update in essential drug lists so that morphine access improves? My third request is for all three of you, which is that you mentioned, in tribal areas, you have made morphine accessible, but I was at the Commission on Narcotic Drugs this year as part of the UNODC, and Global North always says that diversion is the main issue. in India, we don't have evidence on diversion, and I'm sure all of you will agree diversion is not happening from hospitals. There's only one paper from 2001 from Dr. Rajagopal which says no diversion, but there is no other evidence. So if you are already doing it, I would request you all to please document it as scientific evidence that there is no diversion, so that we can then push for better access to opioids. Thank you.
Thank you.
I think
Thank you.
excellent points.
Yeah. Great points. We can start with the first.
Yes, no, I think that's absolutely essential. In fact, we've always felt there should be a state of palliative care. In India, coming out every year, perhaps a report like you have, on education, or you have on different aspects. So I think it's something we would definitely like. It's absolutely everybody contributing to it. So I think it's something maybe at the IAPC we need to look at, but we do need definitely to do this data. I think that would really make a big difference in a sense to highlight the importance of palliative care.
Yeah.
Part can take up this.
Yes.
Yeah.
Part is a capable person and he can do this.
Great.
Yeah,
Great.
no, we were happy to have conversation.
Yeah.
Yes.
And Dr.
Regarding the opioids, I think opioid.
Yeah, Dr. Alok. Yeah.
You're right. In fact, in the national list of essential medicines, we have incorporated morphine and fentanyl both. But you're right that there are many states. In fact, I think only 19 states, as per our records, uh, as of now, have the ready availability of morphine, at least at the district hospital level. But there are at least 17 states from which we don't have any record. So we have put up a proposal in this regard that a communication should go from the central government to all the states to ensure the availability of ENDs, at least at the district hospital level. So that is in place.
Thank you for that. And
Third,
yes.
regarding the research in opioid misuse or something, I think first MD student of mine, Nandan, we have analyzed 10,000 patients in AIMS, and we have published in Indian Journal of Palliative Care, like it is 10 years back. So, similar result that we have systematically we have done with the drug de-addiction center, Dr. Shalini. I think she's a very renowned drug de-addiction is a renowned psychiatrist in working for drug de-addiction program. And what we have found that in a systematically way that there was not a single patient of diversion. So I think there is one more people 10 years back with Nandan. Okay. So
Yeah.
and I think but there are a lot of research are required in this area because people is still even in the biggest hospital where I work, the people straight away they will think patient will die, patient will have respiratory depression, and patient will have a misuse. So I think there are a lot of ways, and we have to. I think if we will continuously we will give results and research publication. I think we can tell them that this is
Absolutely. Pain management is something that is so integral to palliative care, and there's a lot of stigmas around it that needs to be addressed, as what Dr. Bhavna said. And I think that does answer your questions. You'd like Bhavna, Dr. Bhavna?
I just taking
Yeah,
on
yeah,
your point
yeah.
from stigma. The other thing I think we need a lot of education is the education of patients and caregivers as well. Because we talk a lot about good death, living well, but unless the family is spoken to as a unit, to make because I see this day in and day out in my clinics.
Yeah.
So if a patient has made a wish, but unless the family is on board,
Yes.
unless the caregivers are on board, I don't think we can implement that. There'll be a lot of grief and distress if the caregivers are not on board. So I think that is another piece. Education and awareness of caregivers is also very important, which we sometimes forget, I think.
No, absolutely. Thank you for that. Would you like to? Okay. I hope your questions are answered. Yes, I have. Could you give your name and I'll come to you after that? I'll come. Yes. I'll come. Yeah.
Hi, I'm
Take
Olvita
form.
Bhatia. I'm a research fellow at Sangat Mental Health Research NGO in Goa. So thank you for this excellent panel. I think when we started, we spoke about how to improve access to palliative care. We require more awareness. And I really like the direction that this conversation took because we heard a lot about health system readiness for it. But what I wanted to hear more about is what you were alluding to, which is patient and caregiver awareness of palliative care. What has gone wrong and what is going right? I would like to hear from your perspective about what are some ways in which we can move forward to ensure that patients can access palliative care, but there's also better awareness and uptake at a family level?
Dr.
So I
Bhawna.
think so. I am an oncologist. I've been, like I said, I've worked in different healthcare settings. The oncologist has to start the conversation right at the beginning. So, so that it's introduced to the patient in a stepwise manner. Right at diagnosis, a patient is, going through so much, the guilt, the myths, the cultural issues. In our setting, there is another major issue is that we don't tell the patient that you have cancer. So that is another thing we have to deal with in clinics day in and day out. So slowly, how I do it is I start asking the patient, do you want to know about your illness? Slowly, as they gain confidence in me. Because you have to gain confidence before you introduce. But I strongly feel that we must do it earlier in their cancer journey as much as possible. And I'd love to hear what Dr. Gayatri and Dr. Sushma on a practical level do it and what we can do to make it happen.
I think the biggest barrier is physician in themselves because they know patient ask for palliative care in these days in the hospital. They come to emergency, they ask for palliative care, but they say, "What palliative care do you need in this? We can do this. We can do this. I will do this." So I think we have to. Miss like whenever my first thing always remain that we have to educate caregivers and public. It is important, but we have to educate physicians because when they have to set their boundaries, what is the trigger that this patient definitely should go to palliative care physician, it is required.
Yeah, I just want to add to your point what they mentioned. I think the palliative care as a specialty is a lost cause from the beginning. Because what happens, physicians they don't refer because they have their understanding of palliative care is different or they don't know about it. Family or the patients they don't want it because their understanding of palliative care is different. So they get sometimes angry when you say you have to go to palliative care. So it's like giving up. So they get angry or sometimes very upset about. So there it's a big barrier. And the third, which is the underlying reason for all of this is the death, acceptance of death in our society. Somewhere we are finding it so difficult to accept that inevitability somewhere, and that really that's a hush word. And we so can't have the open conversation about these aspects in a normal health conversation which we do. I think these are all the barriers which leads to this, not getting palliative care.
Right. No, absolutely. As they say, we are a bit of a cover-up a nation, which we need to be more courageous to talk about it. Yes. Can you give a? Can you give?
This is Salil Chawla. I am co-founder to one healthcare startup. It is in the space of NCD. That is what has brought me here. Excellent and very informative panel, richly experienced. The question I need to ask you, for me, the elephant in the room in India is as a corollary triple P. As Dr. Bhavna ji said that the gap between the policy, program, and planning. I think if it can be narrowed down or if it can be removed, I think here lies the answer. So anyone can give the solution, as a silver bullet, that how exactly we can narrow it down to improve the chances of any program which is made or laid down, on this palliative ground. Thank you.
Yeah, thank you so much for your question. In fact, that's what we are doing right now in the ministry. We are drafting a policy. Right now, till now, we have a program only. And we had this program since 2013. So, in fact, the policy should have been drafted before launching the program. There should have been a policy first, then a program. But whatever it is, now we are drafting a policy. Now, there we need to bridge the gap between the policy and the program. For that, we are going to work very hard because policy will say something and the program will remain like that, then this won't serve the purpose. So we are going to bridge the gap, what the policy says and how we are going to implement the program. In this direction, we have deliberately put in a section, separate section for implementation of the policy. Usually, the policy document doesn't have implementation. We have deliberately put in the implementation part in it. How are we going to implement this? All the provisions that we have enlisted under the policy document. So we are going to bridge the gap. That is for definite.
Thank you. Thank you for that. I think we'll have one last question where I think the lady over there, if you can give this is the last question for the panel discussion today. Can you give the mic?
My name is Soumya. We've actually been beneficiaries of CanSupport. My father had last stage cancer. So the team visited us. That was a great experience. I wanted to understand what is the role of the private sector, I mean, for-profit organizations in scaling up the delivery, where what gaps can they fill, especially when it comes to at-home or even hospice? Because I think that is also lacking. So maybe Dr. Sushma and Dr. Bhavna can take it.
Yeah.
So I have had huge amount of experience in Delhi within the corporate sector. In fact, in one of the hospitals, I started a CanSupport clinic where we felt that, you know, in conversation, again, I try and bring the conversation in early with the patient and the family as well, because the family has to be on board to take things forward. And we had the team of CanSupport within the hospital I was working in at that time. So I could just walk over and introduce the team. And then, you know, they would take it forward. And at times I visited the patients at home as well. And so I think that is the kind of a partnership and collaborative working that is needed between an NGO, between the private sector. See, the minute we start thinking patient centric, what patient wants and what's best for the patient, you will always do something which is right.
Right.
So, you know, that's what we need to start doing.
Yeah, absolutely.
So same similar experience. AIMS, I have already narrated that how AIMS and CanSupport is working since last 3 decades. In the hospital where I started working, I started one or two patients immediately within first week. I saw that these patients need home care, and when I talked to the home care program of that hospital, they were not having similar such kind of facilities. They means their meaning of home care means giving ventilatory support, giving TPN and all. So immediately within a month, we have developed a home care program for such hospital for the corporate sector also. So let's hope that we will launch this program, and probably we will be able to see that this program is successful and patients will get benefited at home also.
Thank you. Thank you so much for that. We've come to the end of this panel discussion. I'm just going to summarize some of the key learnings that we've had over here, many best practices that we need to take away. But I think the most important is the collaboration across the private sector, with the government, with the NGOs, and at the heart of it is a heart. You know, when you can trust, whether it is as Dr. Bhavna can trust the palliative care, you know, there's a flow of energy which is good. I think that's what's required, and we need to be more sensitive to palliative care and its institutionalization. It's a long way out there. We're hoping that the policy will come into place first and foremost, and then the gaps will come in. So there's still a long way to go. But I think if the heart is in the right place, this journey will go in a manner where it's supposed to go, with so many more people coming into, you know, needing palliative care. I would also like to say that CanSupport gives all of this free of cost. So all the work that CanSupport does for their patients is free of cost, thanks to the AGs, the support, the sponsorship of the private sector mainly, and a lot of individuals as well who contribute. And in fact, there's a latest publication from CanSupport, which is the guidelines on home-based palliative care that is being shared as a best practice that can be taken and scale can happen. So there's a lot of work on that front. And of course, CanSupport has been recognized by WHO as a change maker and have been awarded many recognitions. And on that note, I will close this panel discussion. I thank all of you for your wonderful questions, very thoughtful, very added to the value of this panel discussion. And most importantly, I have to thank all the panelists for their heart, for their knowledge, for their expertise, and the fantastic work that all of you are doing. And thank you so much for that. Thank you all for being here. I hand over to Anand.
So thank you everyone for a very thoughtful and very thought-provoking conversation. So now invite Radhika for the felicitation.